Thanks everybody for joining us today. We've got a special guest with the Vascular Guy. For those of you that are on the progressive edge of social media, you may already follow him and his genius and all of the ways he likes to teach and show things on the cutting edge. And his
Oh
taught me
boy.
about SecurAcath with his intuitive nature to assessing and analyzing all of the corners and angles and how things work and how things don't work. So I would love to hear from you, your questions for him. So please use the chat function or unmute when you have a question. Just use the raise your hand function and I'll call your name. If you want to remain anonymous, you can post your question in the chat to me, Laura Crick, and I will be happy to moderate the question to Dennis. Dennis, the Vascular Guy, I keep calling you by your name.
Okay. They're gonna find out someday.
What would you like to tell us? What are you showing on?
Yes.
It's quite fascinating, and I'm curious about
Let's
what you're going to show us.
let's start with the basics. For those of you who don't know what this is, actually, can we get a survey in the comments? Can you write I know what this is or I don't know what this is? I just want to get a quick poll or survey of where people are at. So if you could put in the comments, let me know so I can speed through this if you already know what this is.
I got an I know and I don't know.
Okay, cool. So we're gonna go over this, and this is a blown up model to show you how to manage it, how to remove it, how to apply it. What is this? This is a sutureless. Okay. Can you guys see that? This is a sutureless securement device. And also, we're gonna be here for what, at least 30 minutes. So if you got friends who might need to know this or this will be benefiting for them, go ahead and send them the link to this Zoom because they're gonna want to see this. This and we can answer questions immediately. So it's going to benefit for those who are here today. You can ask questions and get answers very quickly. This is a sutureless securement device, a subcutaneous sutureless securement device. Why is this so important? Because then we don't need to use the adhesives that are going to irritate the skin, not really hold really well, or avoid sutures. And what's the problem with sutures? I know a lot of clinicians are like, hey, I suture all the time. It keeps it in. It does, but the nurses can't lift it up and clean underneath. And you got all that surface area for microbiome to grow. And the nurses aren't able to get under it because of the way it's sutured. And of course, most people who suture it have it very close to the insertion site. And so that causes problems. So it prevents pistoning. It allows for nurses to be able to scrub properly, and it also helps with those with hypersensitivity to adhesives. So if you're allergic to tape or acrylic or some of these harsh adhesives, this is a great alternative for you guys. It's worked really well for my MCAS and EDS patients, and we're going to go over special considerations for them. I have a special place. Dysautonomia patients have a special place in my heart. The Dysautonomia International organization actually fired me when I was a DJ back in the day, but they have really good information and they do really good work for patients with that disease. And so when I was there, I learned a lot about how they're being misdiagnosed and mistreated. And so I want to really hunker in with educating clinicians and patients about something like this that can avoid those problems. So first, let's talk about insertions. So if there's anybody that wants to ask questions during this, please put in the comment. Laura's going to interrupt me. This is your time. If you want, like, I'm not here to show this off. I can do that on TikTok. Right now, it's for you so that if you have any concerns or questions, we can answer it right now. So just know this is your time. And so please feel free to interrupt, and Laura will interrupt me with questions as it comes through. So imagine this is a skin surface, not a vein surface. Okay, just let's keep that clear. But let's pretend this is skin, not vein. All right, here we go. So I'm going to do a regular insertion. All right, there we go. Through the skin, and I want to poke that. There we go. So you have your needle here, and we're going to take our guide wire. Oh, sorry. Let me see. Does it zoom in? Oh, it's zoomed into the. Okay, I think you guys can see that clearly. Let's see. So I'm going to insert the guide wire. Jeez, there we go. Dude, do you guys see the? Let me know if yes or no. Do you guys see the guide wire going in and out, or is it out of frame? Can you
Nope.
guys let me know in the comments?
It's a little blurry.
A little blurry. Let's try this. I think I need to
That's
start
good.
from.
I mean, that whatever, I think it's just the focus on the camera.
Yeah, it's the depth of field. There we go. I think that looks a lot better. Does that look more in focus for you guys?
Yes.
Let me see if that helps. How about that? There we go. Okay,
Yep.
cool. So we're going to feed. And you guys see the guide wire going in. Okay.
Yeah.
Yep. Your arm
So
crossed.
this is the guide wire. We're going to pull the needle out, maintain access. We're going to put the dilator in. And I hate breaking these dilators uh, because it's like a one-time thing and I'm cheap, but I'll do it for you guys today because I love you. So here we go.
I
There's our
believe it too.
dilator going in under the skin, and we're going to insert. I don't know if that dilator can reach. There we go. So that sheath is in. I don't know if you guys can see that. The sheath is in, the dilator's in. We're gonna maintain access, and we're gonna take out the intercannula dilator. Can you guys see that okay?
Yep.
Sorry, I keep
You're
moving
good.
my
Yes.
hand. Okay, cool. Shauna says we're good. And I'm going to break apart the sheath so that I can reach the vein or the skin, sorry. And see if it'll fit. There we go. A little sensitive there. Try not to lose access. There it is. Okay, here we go. Uh, there it is. Okay. So what I like to do is lift the catheter back and then insert in. Now, let's say you're having trouble. Do you guys see how the feet is not actually going in really well? What you want to do is make sure that the feet and legs are in. If the feet do not go well, but you deploy it anyways, you're going to see, well, if you can,
Yep. The cross.
yeah. So the legs crisscross and they're not straight. They should be. Will it focus? No.
Not focus.
Limitations of zoom. Okay.
There.
So there we go. When the feet are deployed properly, there it is. You're going to see that they're parallel, but if they're not, you're going to see that the feet are crossed. Can you guys see the difference between this and this?
Yep.
Okay. So say from here, this might be easier. The feet should be parallel. There should be a nice line divide. But if it's not in properly, you'll see it crossing like this. And so you want to make sure it's in the subcutaneous tissue properly. So if you're having any trouble putting that in and it's not going in all the way, this is a troubleshooting technique for those of you who have done this before and having difficulty with that. I don't like to nick because that's going to reduce the efficacy of this device, but also you're going to increase risk for infection and just in general, avoid nicking if possible. And this is how I avoid nicking, which is using the dilator, the intercannula dilator, to open up that hole just a little bit more. It's going to go in. Boom. Now, I don't know if you can see it in the camera. Yeah, it's hard to tell.
So Dennis, you zoomed out so we can't see what's showing on the camera.
Oh, aha.
Yep.
Let's get closer. So you want to rest it in there. So down here. Let's get back down here. Do you see how it's anchored in? You can even see the transparency of the latex a little bit. There's feet on both sides. So I usually look for a nub on one side, left to right, and then I attach the catheter inside of these rubber I call them bumpers. What do you guys call them?
Yeah, towers or bumpers. That's right.
Towers. So there are these rubber bumpers here. I apologize. I'll have to get a camera that can zoom. Bumpers, and then your catheter rests in between those bumpers. And then you want to apply the SecurAcath on top. And you're going to want to hear those clicks. It's going to click in pretty well. Okay. And how do you know it's in properly? When it's flush. When the
Okay.
lines are flush, it's not a little bit open. It's completely closed when it's completely flush on both sides. And you can see that the catheter is resting inside the center. So what this does is it allows us to keep this catheter from coming out. And look at this. Look at how much I'm moving it. And we're going to watch a video of a dressing change of how quick and effective this is. This is why I like SecurAcath, because I can clean very quickly, do my care maintenance very quickly, in and out. Now, what's going on underneath? Let's watch. There we go. This is what it looks like under the skin. Let me see if I get a good opening here. There we go. Can you guys see that?
So the question we just got this was,
Yeah.
must be painful for the patient. Anesthetics? Question mark.
Ah, yes. So we use this for traditional MST procedure and catheters. So where is it? Things like this, where you require a dilator. MST means modified Seldinger technique. That's a really good question. So it's these types of midlines and PICC lines where you have a much thicker bore, usually 3, 4. How small do we go to? 2?
2.6 French up to 12.5 French is the largest catheter we'll hold.
So these types of very flexible catheters that go in quite long, usually anywhere from, I would say, 8 centimeters all the way to 60. And so it's meant for these modified Seldinger or Seldinger technique catheters, not the AST or the advanced or the different catheters. So
Using
you think it would
anesthetic
hurt?
as standard of care, right, Dennis? I mean,
Yes. So when we're doing these, we apply and inject lidocaine at the skin. So hopefully I could pull up a video. You'll see during the procedure, they don't feel anything. In fact, I'm digging in there. They can't feel nothing because I give a generous amount of lidocaine, especially for this part of the procedure. So they don't feel much from it during the procedure. Now, what about after the procedure? What about after the lidocaine wears off? If placed properly, my patients have not complained yet of pain. Now, our dysautonomia patients, our connective tissue disorder patients, I'm going to go over the exception for them. However, you can see that, of course, this is a tubing, so you're not going to get a real good representation of what's going on under the skin. But once you're under the skin, do you guys see how freely it's moving around? Is this part out of frame, or is this in? Can you guys see that metal moving around?
yes. And again, for everybody who might have joined while he was explaining the beginning, this is meant to represent subcutaneous, not the vessel, but the distance just below the skin.
Yes. This is not supposed to be a vein. This is just a representation of skin. And so you can see how it's anchored in really well. And once you pass the cutaneous tissue, it's kind of free floating like this a little bit. Okay, because the subcutaneous tissue is the tensile strength of the skin, the dermal layers are very thick, and so this will hold the catheter in place without causing harm. Remember, majority of the pain sensors are in the skin, intradermal. So you don't want to deploy it while you're in the skin. You want to deploy it. Do you see how my feet, let me see if I can show it a little bit better. Do you guys see my feet are in, but let's say they're not all the way in. Do you
Yep.
guys see how it crisscrosses the legs? This is going to cause a lot of pain just by sitting in there because we've essentially just deployed it inside of the skin where all your sensory receptors are. So all your pain receptors are being stimulated whenever this moves, even just a little bit. And so we want to make sure we're fully in the skin, subdermal, not intradermal. Do you see here? Oh,
Move it. Yep, there you go.
do you see here how we haven't punctured all the way through? But if we deploy it like such, then it's going to stretch and stimulate those pain receptors. So we want to make sure, let me get it in. We want to make sure they're all the way in. And let me do it towards, there we go. So we want to make sure that it's, there we go.
So we got another question, Dennis, as you're demoing.
Yeah, go for it.
Question. It says, do you have any complaints with additional oozing during or after the device is placed?
Ooh, that depends. If I nicked because of like scleroderma or my dilator trick didn't work, it rarely happens, but it happens. Oozing at the site is not so much of a this problem, but the whole problem. How
Okay.
big of a hole did you create? This is why I don't like to nick, and I teach my my orientees not to use the scalpel if we can avoid it. So, do you see how the feet are going in? They're not touching the skin intradermally from underneath, or really, they're not going to puncture. Do you see how round? Look at how round these edges are. These are laser etched, and I believe they're manufactured here. Where are they? Where are they made?
It's yep, in Minnesota.
Yeah. So they are pretty good about quality control. Do you see the edges here? It's round. It shimmers like that because it's round. If it wasn't, you'd see a dark edge. But because light is able to reflect on a larger surface area, you're actually looking at a rounded laser etched edge compared to a sharp edge. If it was a sharp edge, it'd be a much darker fine line because you can't reflect light off of a sharp edge as easily. And so you can also see at the feet, it's very, very round and very soft. My needle will cut, but this SecurAcath, do you see it cutting the latex? This rubber latex is weaker and more susceptible to cuts than a regular vein, or sorry, not a vein, skin, subcutaneous tissue. So you could see me gliding and pressing up against the latex, and it's not cutting anything. So you can be rest assured that this isn't going to cut the inside of the skin. And again, just to reiterate, I'm going to talk about the special considerations for our connective tissue disorder patients, but for the majority of the population, it's not a problem here.
So
And
Dennis,
so
another
go for it.
question. I'm sorry I keep interrupting you.
No, please do.
So it says, how would you know that you're all the way in? And then I'm going to ask you a second question because we're starting to get the questions now.
That's a great question. I know I'm all the way in by a couple things. If I could put you, oh,
Yep.
right there. Do you guys see? Let me show you the difference. I may be getting this wrong, but I call this the feet and I
Yes,
call this my legs.
correct.
Okay. So I want both feet and legs as deep as possible under the subcutaneous tissue. So let's say this is the skin, all right? Let's say that's the skin. I want both, not only my feet, but I also want the legs to go in. And do you see how much? Remember, keep in mind, this is not a vein. It's a poor representation of a skin right now. I'll get a larger tube and we'll play around with that later. But do you see how my legs are fully in? If my legs can be fully in, this is one part of diagnosing if you're in or not. This is one way that you can tell. Now, is this a perfect way to tell? No. The best way to tell if you're actually fully in or not is if your legs are not crossed. Do you guys see that space in the line? Let me see if I could show you off this camera. There we go. There's my zoom. Do you guys see how the feet are parallel? Can you guys all see that? Or is it too bright?
Nope.
Let me know in the comments. Is it too bright or is this enough? Do I need to turn down my
You're looking good,
Shauna
Dennis.
says okay, everyone's good.
See it? It's good.
Alright, okay.
Responses.
So if that is parallel, then we are good. However, do you guys see it on this side too?
Yep.
There we go. Do you guys see how much more parallel it is now compared to
Forcing the failure is hard to do.
yeah, making it not work well. So, all right, we're giving up the camera here.
There you go.
Do you guys see the legs?
Back it up a little. Right
There
there.
we go.
Don't move.
Do you guys see how the legs are crossed?
They look on top of one another.
And let's look at it from the, I think from the back, you'll be able to see it better.
And this may be where your jumbo model comes in handy, Dennis.
Yeah,
You can fake it with
there
that.
we go. Do you guys see that point here? It's crossing. There it is. That's a little better.
Yeah.
There's too much light in here. Do you guys see how that's crossing?
Yes. Everybody says yes.
Good, good, good. That
Really
means we're not fully in. And you could even see the tension. Do you guys see how much tension that catheter is being placed on this tissue? You guys can see that nub, right? So that means the SecurAcath is actually intradermal. Subcutaneous tissue is very malleable. It's very soft. Dermal tissue is very
dense.
hard. There's a lot of tensile strength there. I need to find the scientific word for that. So this lets you know you're in wrong. And then let's make sure it's in right. Yeah.
How do you correct that, Dennis? I have a suggestion, but I want to see what you would do. If you're partially in, if you're in the dermis, it's almost there.
Yeah, if it's partially in, I will go into, let me try to get this back on. You know what? Next time I'll do a Velcro.
And Amanda, I know your question's there. I will ask it. So just know it's coming up.
So I'm going to use this dilator at that hole where the catheter was. And I'm going to point it down here. That dilator where the catheter was, I'm going to use that dilator to create a bigger hole. And so that's going to open it up a little bit more. And I'm going to even stretch it. It really depends on the patient's skin, how much I need to manipulate that. And again, I'm doing everything I can to avoid nicking that skin. Taught to me by Dr. Jack LaDunn, the one and only. Real pain in the butt to deal with, but it ends up being a time saver and a big deal for patients. So while I'm doing this, if the feet had a difficult time going in, I will try to get that all the legs in all the way. Now, of course, this looks really bad because this is a tubing that's really short. But remember, in real life, they have over centimeters, multiple centimeters of subcutaneous tissue that's going to be freed open. So I try to make sure my legs are in and not just the feet. And let's see what that looks like. So I try to make sure that that's in all the way. And if I let it go a little bit, it doesn't like spit it back out. It's actually, I'm able to let it go and it stays. And the legs stay submerged under the skin. I know I'm good. But if it's not good, you may compress the veins, but it'll actually end up spitting it out. And it won't let you submerge comfortably. When you release the tension, it won't let you submerge those legs if it's not in properly. So I will do a couple of techniques here. Let's say the catheter's in. I will go behind the catheter and try to go in from this side. I'll try to go in from this side. whatever way I can sneak the feet in, I'll get it hooked. I'll even like try to zigzag my way through that dermal layer as much as I can, and then zigzag my way in because I really want to make sure 100% that this is underneath before I deploy it. That this is going to be underneath the skin. I had a patient who one time and after the PICC line was placed, she called and complained that there was a lot of pain and discomfort after about 2 days. One day, I told her, there might be some trauma to the skin because of the dilator and what we did. However, she did complain that it still hurt after 3 days, and the SecurAcath probably was not in properly. It was one of my first few that I placed, and I did not know that the crossing of the legs was an indication that we weren't in right. And I remember distinctly seeing that. I was like, well, it's in, it deployed, it was able to expand, it must be in, but I didn't check to see if that was parallel. And so I knew, looking back, I don't think I was in deep enough. I just got in the skin and I was like, okay, I'm good, finally. And then I just deployed it. I didn't make sure I was deep enough. And so you want to really make sure that that bad boy, the legs are really in there in the skin.
Dennis, I'm going
So that's, yeah,
add
go for
what
it.
you're saying, 2 points, and then I'm going to ask you another question. While I'm asking, the 2 points I'm going to make is as you're placing it in, what you were showing in terms of having the feet parallel to the insertion site and scooping it in is the best strategy from what I've observed. And I think the second thing is to always make sure the opposite hand, I think as Jack likes to say, we got to make sure we don't have a lazy left or a lazy opposite hand. You got to hold the tissue tight and taut as you're approaching the insertion site. That opposite hand almost serves an important or more important purpose at times as the hand that's actually manipulating the device to place it. So now that you have it in, Dennis, the next question is relevant. So have your pad out because I think the way you're going to answer it should
Go
be
for it.
that pad. It says, what tips can you give to control any oozing using this device? Just apply pressure. Can a pressure dressing be utilized with this device if needed? And I have a tip here that's really, really important, but I want to let you go first.
Yeah, for sure. So she's concerned about, or he or she's concerned about oozing, correct?
Yeah, post-insertion site bleeding or oozing. Maybe you have an anticoagulated patient and you've got the catheter and the device ready to go. You want to stop that. You want to get that hemostasis before you put that dressing on. So what would you advise?
Correct. So I advise get the catheter. So I like to, this is how I do it. I like to make sure the SecurAcath is on first before I try to do anything to manipulate clotting or promote clotting. So after that, to be honest, I just apply pressure and if I need to sit there for 10 minutes, I'll do it.
Well,
Now,
now it's really important, Dennis. This is where I have a tip I want to comment on.
go
Not
for
just
it.
put pressure on the surface, but you need to cinch back on the SecurAcath and catheter a little bit because there's a tiny gap between the two. And you want to close that gap and have that hemostasis form at the base of the feet. So to close that gap, you want to pull back all the way and cinch, almost creating a tiny form of tension as you're holding pressure on the surface. So to hold your initial hemostasis, pull tension on the SecurAcath and catheter as you put that topical pressure on it. So pull back so that the legs and catheter come together. You see, perfect. Thank you for showing the perfect angle. Now that opposite hand should be holding digital pressure on the surface. So those two things in conjunction will get that stasis to form at that subcutaneous level. And then you can apply, if you have an hyper anticoagulated patient, you can apply an additional solution, whatever the hospital's policy is. Some hospitals use stat seal, some use glue, some use different things. But to obtain that initial hemostasis, that technique is the best technique I've ever learned. And I learned it from the folks in San Francisco. So
Yeah, I've tried glue. If they're still bleeding a good amount, that glue is not going to do anything because, or it's going to do minimal work when you leave. I've had people continue to bleed. So the glue will work if there's no bleeding, if there's no liquid coming out of that site, and you're afraid that there might be later down the road. Um, Putting pressure at the venous puncture site is going to be key before you apply the glue and make sure it's dry. If there's any exudate coming out or any blood or any liquid in that site, that glue is going to be mitigated. So just make sure it's fully dry before you try that. Hemostat also works if you want to use that as well, but I don't carry hemostat um, on the regular. I'll have it as an emergency for like profuse bleeding, but for the most
Stat
part, if
seal.
I apply stat
Stat-
seal, yeah, sorry.
Yeah.
So yeah, not hemostat.
I
um,
was making sure.
I'll yeah, yeah. So I'll apply pressure in usually 5 minutes. I know it feels like a long, long time, but 5 minutes, 10 minutes, it really helps to start that coagulation process. So yeah, I hope that answered your question. The oozing issue again is dependent on how much of a nick you made, how big that hole was created, because whether you have this or not, you're still going to have an opening, a large opening for liquid to come through. So you really want to seal that as best as you can. And to do that, I use a dilator. I don't nick. In Brazil, don't use glue. Oh no. Yeah, it's a good alternative, but I prefer to apply pressure, especially for bleeders. It's there's nothing better than the human's clotting process to really stop it at the inside. You can't really inject anything there. So
Yeah, but I
those are
also advise that, they don't push themselves out of bed 5 seconds after you're done putting the dressing on, and that they don't arm wrestle their nurse after either. So, like, minimizing movement for the first few hours post insertion is also good advice to give. That's just my observation. I always see the bleeding happen because I watch the patient push their body up out of bed, and and that's a lot of force on that point that you just
opens up
created
that.
that. Yeah.
Yeah,
So
exactly.
that's a good question. I want to remind folks that might have jumped into this meeting a little bit later that you can post questions here in the chat. We want to make sure we get everybody's questions answered. So feel free to post your questions in the chat. If you want to post anonymously, you can direct them directly to me. If not, again, I'm moderating the chat for Dennis. Dennis is going to keep talking and share some tips and tricks. So why don't you show us how to remove it, Dennis? What's the best technique for removal?
There we go. So I you could there's two ways you could do this. First of all, you need to do you guys there we go. Do you guys see where it says lift here? Got a camera. There we go. You guys see where it says lift here? So you want to lift from this part and then hold down from this part where it says hold. So I'm gonna hold where it says hold and then lift, and you'll see,
We gotta zoom. Yeah. You need an
and
extra
you'll
second.
yeah, I need a cameraman. And you can see that little tab here. I'm gonna lift that up. And actually, I wonder if I can show you. So it says lift here. Try from this angle. Lift, and then just look at it from this angle. This is how probably your point of view here. I'm gonna hold that and then lift that off. So there's two ways that you can take this off. What I like to do, and we'll use this one. So what I like to do is while we're in the skin, I like to fold it and then rotate and then pop it out like this. Is it going to be like easy as this for every one of them? Of course not. However, this is the motion that I like to use the angles to my advantage. So let's look at it from here.
And Dennis, as you're doing that, I'm going to emphasize another key point here.
Uh-huh.
Finger grip technique on the base is really important. So holding the wings together between your thumb and middle finger with your pointer finger on that blue ridge gives you the most control as you're doing your removal.
So I like to like that.
Need another stand.
I do. There we go. So there it is. So I'll do this, pull it out, and you'll feel that feet get caught. I mean, it's kind of what it's made to do. And then I'll pop out like so, like this. Now, some people may have issues with that or have trouble manipulating this. So what I'll end up doing is, I don't want to cut this one, but you can actually, this blue part, is it rubber? What is this made out of?
It's an elastomer. It's
It's an elastomer.
Mhm.
So you can actually use scissors
There's no
to
latex
cut it
in the
apart.
product, no rubber.
No rubber, no latex. So you can actually cut that blue part off. And then what that actually ends up doing, oh, I don't want to waste these, but let's do it. It separates the feet. Now, don't use a
Don't use
knife.
Hey, where's your
You can
scissors?
use, you can use, I don't have any on me.
Oh, don't do it.
So you could, actually, you know what?
Use a carpet
I?
knife on it.
Don't do it. Don't do that. Whatever you're doing, don't do that.
Don't use a carpet knife, but use scissors. Okay, let me see.
Blunt tipped scissors like these.
There we go. So, wow, these actually don't break off easily. I love it. There it is. Okay. So, I cut these with scissors and it comes out like this. Okay, so let's see what it looks like down here. So, now that it's apart, I don't have to worry about trying to like manipulate it or bend it. A lot of people when they're starting out, when I started out, I felt more comfortable cutting it up this way because I wasn't really good with the muscle memory of manipulating it. So I just cut it up and took it out 1 feet at a time. And that could be a little easier. But
The
I
counter
prefer
traction
to
is
just
key. So as you
say
pull,
that
you
again.
like the counter traction at the skin is very important, even when
Ah,
you
yes.
cut the base.
So, correct. This is not a loose human skin. Our skin moves a lot and it's very loose. So it gets in the way of removing and applying. So what I actually do, which is what Laura mentioned, I apply tension to the skin. I take my gloves and I apply tension, and it helps me to remove this better because it's not lifting. The skin is not lifting with the SecurAcath. And so I like to keep tension on that skin and then pull it out. Sometimes I'll have them cough, and while they're coughing, I'll just do a quick like pulling out teeth, just real pop, like a loose tooth. I'll do a slap. Oh, another thing is if they've had it for a very long time,
We're not seeing that upper screen.
uh, if they've had this for a very long time, there's going to be a lot of crusts, a lot of tissue, dried exudate fluids that are going to be crusting over and kind of making it difficult to remove that leg and feet. So what I'll do is just apply sterile saline at the site so that it can loosen up all the crust.
Yeah.
And so if I see a lot of blood or old blood or still some yeah, crust is the only word I can think of. There's a lot of crust there. I allow the saline to soak. Give it
Hypergranulation.
time to say it again.
Hypergranulation.
Hypergranulation. I love it. So retro.
Ruh-roh. And
So
We recommend saline soaked gauze. So sometimes just putting like a 2x2 soaked in saline at the site and leaving it there for a minute or two, maybe 3. Getting as much of the loose matter off. And then if it still looks tight, or it looks unusual in any way, that granulation tissue is at all unusual in visualization, I would soak it to soften it so that tissue is more pliable at that insertion site.
Preguntas? If a patient, what was that?
I had a patient, it stuck on her skin. So maybe, Dennis, this is where you can show that ninja technique, as like Mr. Gibson likes to refer to it, where the cough and pluck.
Yeah. So that's where I try to time it. Let's say, so I like to get it so that the feet is right up against the skin, the top of the skin. And then I'll have them cough. So I'll say, all right, you ready? 3, 2, 1, cough, and then boom. I actually have a video if you guys bear with me real quick.
That'd be
I will
great.
show it to you because I have it saved. There we go.
Often what we've seen in the hotline while you're pulling that video up is that it's more about the technique and the orientation of it than it's actually physically stuck. There may be resistance, but that counter traction helps to alleviate that resistance. And the angle of approach is really important. That blue seam, if it's cut or if it's folded, that blue seam should always remain as parallel to the skin as possible, because that should orient your mind to where the toes are. So the wing and the toe are in the same plane. If you're folding the device down, now you're bringing your feet down into that sub-Q tissue and you're plucking them out of the insertion site. If you are separating them and you're cutting them into 2, then it's a counter traction over that foot and then a swift, brisk, and confident removal. It'll spring out. So they are just spring through the insertion site.
Can you get, oh.
I'm gonna pin I'm gonna switch your pin. So give me 10 seconds here, Dennis. Sorry. I am
Oh, it
trying.
shows both the camera and.
Yeah. I'm gonna try to switch it so that this is your.
Interesting.
Okay. You're good. You should.
All right, so
You guys see
here
that?
is the SecurAcath.
Yep.
I'm gonna don sterile gloves. Do I have to? No. Do I like to?
Volume down a
Yes.
little.
Just to show you guys how easy it is
I
to
don't know if
remove
I can't.
or to clean this. I'm gonna clean around the site. You don't have to. It's recommended, but there's no studies to prove that this actually reduces infection. But I do like to do it if I can and have the time. I know it stings, right? I'm sorry, hon. So this is why the SecurAcath is preferred, because you can move the catheter around without the risk of dislodgement. This has been in her for a while. Another trick is to take sterile saline flush and wet the insertion site so that it loosens and softens the skin or the tissue around the SecurAcath before
Sorry
you pull
about
on
the
it. So now, as you can see, there's a lift and there's a hold. So we're gonna hold where it says top will come off. There we go. Because I'm gonna collapse the wings like this from under her skin. Okay. And so, hon, on a count of 3, I'm gonna have you cough, okay? A big cough. All right, 1, 2, 3. And that's it. Did you feel that?
It's gone.
That's what was inside of you.
That's it.
That's it.
And they couldn't do that. Oh.
So hopefully we can get you guys to do it.
So
Any questions about that video?
Dennis, I'm gonna try to flag you again. So give me 10 seconds here. Pin spotlight. There you are. So I think that technique really, really works well. And again, the key points are counter traction at the site and the right angle, the proper orientation. Can you hear me?
Yes. Can you
Okay.
hear me?
Yep, we're good. So the second question along the same lines is, I'm going to read it's sort of a statement with a question. It said, someone told me that they were told to tell the patient to massage the area periodically to avoid the device from developing scar tissue. They said the patient once came in and it was so stuck that the physician had to cut it out. Is massager movement needed while inserted? So I'm going to answer that one, and then you can give commentary on top of it, Dennis. So it is really important during the site care, as Dennis had in that video, that we're lifting the device so that it's perpendicular to the insertion site. This motion, this proper motion, is really, really important to breaking down hypergranulation or tissue formation. If we're babying it or we're not lifting this adequately, then we're going to see more scar tissue formation. If we lift, we're going to break that down every 7 days or as dressing changes are conducted. Again, it's really important that we're lifting this so that it's perpendicular to that insertion site when we're doing our site cleansing. It also gives you access to the device 360 degrees, so you get that proper cleaning all the way around. Jeff, you got to watch the waiting room for me and let people in. So that will break down that hypergranulation. Massage will work, but I don't know that massage alone will work. It is really important to lift when we're cleaning, and that will help to break down, again, scar tissue formation. But if you observe it, if there's hypergranulation, different people heal in different ways, then it is our recommendation to use that saline soaked gauze to soften that tissue or that scar tissue formation.
So
Go ahead, Dennis.
I would, if you can put in the comments a little bit more behind that story, because I think this would be a great segue to talk about our connective tissue disorder patients.
Right.
So dysautonomia, MCAS, EDS, usually even autoimmune in general, there is a connective tissue problem. What does that mean? That means the connective tissue that's supposed to be holding everything down, or even the tensile strength of certain cells and certain tissues of our body, they don't bond, they're not bonded really well. And so they're very loose. And what happens there is it allows for things to, like, pressure ulcers are much more easily developed on these people. Their skin is either growing at a faster rate or not as healthy with tight bonding between the cells as much as they should be. You'll notice that younger patients with very rolly veins that move around a lot, they tend to have a connective tissue disorder underlying that vein moving, because our connective tissue is supposed to hold that vein down a little bit better, but they can move for miles because nothing's anchoring those veins down. And so those are patients that we need to have special considerations for with our maintenance and dressing changes. Let me see. If you look at this, actually, let me change camera real quick. There we go. So if we look at this, and I'm actually might put a hole in here for that one. This has, could you remind me, what is the degree of pitch?
6 degrees. Sorry.
So it has a 6 degree, it's not perfectly flat. It's actually bent a little bit. Let me see if I can show it here.
Yep. There you go.
Do you guys see how there's a little bit of a downward angle? It's doing that on purpose because we don't want it to be completely flat. That way, this allows for less tension under the skin. Now, for our connective tissue disorder patients, what I have found is they are more susceptible, even with a pitch that avoids too much pressure underneath the skin. I found out for them, even the smallest amount of pressure, they're very sensitive to this. And it's not just SecurAcath, just in general, their physiology is very sensitive to any amount of pressure. And I'm going to show you a video in a few minutes of a patient, even the hub just being taped to their skin started having effect on them. And so these are exceptionally sensitive connective tissue disorder patients. So what I would like to do is put some kind of gauze or padding underneath the dressing so that it maintains a much sharper angle and not a more gentle angle. That way we're not putting too much back tension underneath the skin. Now, have you guys, let me know yes or no, have you guys seen some of this stuff like through the skin? Like, it was so intradermal and so shallow that you could actually see it.
I can talk about one that I've seen.
Yeah.
Yeah, so I did see this once, and after we assessed the situation, what we learned was that it was actually turned in its plane, or in its point of view. So I'm gonna take your spotlight,
Go for
not
it.
not to take your sunshine there, but
No, please do.
but what I saw happen was that it was placed in this orientation, but during a dressing change, somebody decided they wanted to move it to a different angle. And that actually made the foot rise up based on the orientation of it and the plane that it was laying in. So the wing was poking upward when it was sitting. And so it was visible to the surface. And eventually that upward pressure actually kind of eroded through that insertion site. And again, if it had been kept in the main plane, that occurrence, that situation would not have happened. But it was due to repositioning and having that one foot kind of oriented on an angle out of plane. So it's really important from our point of view that we maintain the position in the plane, and make sure that the depth of insertion and the depth of orientation is key.
So for the majority of my patients, I don't have to be worried about this particular issue. And I'm going to show you an actual dressing. There we go. What it would look like. So this is for generally our dysautonomia patients, MCAS in particular, for our connective tissue disorder. And if that connective tissue disorder also comes with autoimmune, that tend to come hand in hand with each other. So I'm going to show you what this looks like. What I like to do for these patients, and I usually ask them too ahead of time, hey, do you have connective tissue disorder? And they generally know, unless it was a new diagnosis, they generally know if they do. And so we're going to take that. And so we're going to take this dressing.
And Dennis, I'm just
And
giving you a heads up. We've got 2 minutes left. Time flies when you're having fun.
perfect. All right.
If anybody has last
So
questions, please post them in the chat while he shows this.
so I take like a gauze. This is just a sterile dressing. I don't, for some reason, this kit didn't have any gauze in it. It's interesting. However, you take a piece of gauze and you put it under. It doesn't need to be this exact angle shift, but something. Actually, let me do this since I've got nails. Let's assume we have a small piece of gauze where we were able to cut it. I'll take it and let's get that camera back up so you guys can see it better. There we go. My dressing.
Are you going to use a bio patch? Somebody's asked.
Yes, I gotta show that one
Okay.
because
Well, thanks for those of you. We're going to go a little long on this call, so stay on if you're interested to hear and see what we've got. We'll continue going for a little longer.
yeah, so this is going to be key for our dysautonomia patients or connective tissue disorder patients. So can you guys see this camera? There we go. Bam. There it is. All right, so usually when we're putting the dressing on, we put it on flat, right? But the problem with that for these patients, there's a little bit of tension. You can even see it. There's a little bit of tension of that feet pressing up. So what I like to do, and again, people without connective tissue disorder, this is not a problem. I've dressed it flush, never had a problem with patients who do not have connective tissue disorder. But with people with those special exceptions, I like to have the angle going a little bit steeper and then hold it there, hold that steep angle. Okay,
And
so I think you guys got the idea behind there.
so the key is stabilizing those wings and giving that stability.
Oop. So we're going to move this up like that. There we go. So with these patients, I like to keep that angle maintained with gauze. And it's up to you how high you want that angle. Okay. And then I apply the dressing this way. And this has increased the longevity of people with these with this particular problem. Given this technique advice to a few home health nurses with patients with long-term catheter use and SecurAcath, and they needed SecurAcath because the adhesive was a big problem for them. And so what they would do is apply it at the insertion site first. I make sure that's tackified. And then I don't slam it down. I actually pinch and try to touch and tackify the SecurAcath itself. And if you look from underneath from this side, if you look at it from this side, do you guys see how I'm not slamming that down?
We got a low battery warning.
Look at
Right?
it from let's look at it from here.
There you go.
There it is. Can you guys see that? I'm not slamming that down immediately. I'm actually taping it so that there's a little bit of a lift maintained around that catheter. Are you guys able to see that angle difference? Let me know in the comments. So we'll show you BioPatch in a second. It's going to be the same issue.
We got some yes and thanks.
Good, good. So I pinch it instead of just slamming it down like we normally do. That way there's some wiggle room for it to not be cause that angle tension up. So that's without the BioPatch. All right, let's do it with the BioPatch. So how do you remove this? Have you, Laura, have you come across using the CHG gel? Does it lift off the SecurAcath at all?
Yeah, so the recommendation from 3M on that, or now Solventum, is to use saline to alleviate the hydrogel. So that gel square, you want to just squirt a couple drops of saline and it'll come right off. It activates the gel and makes it very easy to peel. So if you just give that a squirt, right as you peel to the edge, it should come right off.
Yeah, it feels great.
Look
Okay.
how easy that is.
There you go. Yeah, that comes off pretty easily.
By the way, same for removing it off of the skin. You just give it a little squirt of the saline as you peel away, and it should come right off. It should lift right off without.
So
tension on.
somebody asked about Ivy Clear. Hey, look at that. An
So
extra
any
one.
dressing from SecurAcath's point of view, any dressing, any add-ons, any combination that your hospital prefers, we are compatible with. We've tested the gamut. So
Correct.
it's just knowing how to use each device and each combination to the optimal level. Our team is trained and educated to support you. So we want to make sure. Yeah.
Here's the issue with any kind of antimicrobial disc. Because it's not covering the entire body. I don't know if you guys, let me see if you guys can see that. There we go. Because it's not covering the entire body, any amount, it turns into a fulcrum, a much more elevated fulcrum, which means if you try to slam this down with the dressing, like so, that's going to cause even more tension and more pressure from underneath. And so these discs, you have to be even more mindful.
Floating the dressing. Yep.
Yeah. You want with this disc to match an even higher angle. So I probably need a bigger piece of gauze
On a
to
real
reach that.
doesn't have that extreme. This square pad definitely, I think, over dramatizes that, but you don't want to counter pressure that base.
Let me see. When that BioPatch is under and you try to slam it on the skin, I mean, I wish I could show you what I'm feeling. There's so much more pressure pushing it up. And so you want to avoid that by putting something underneath it to
Or-
prevent
yeah.
that fulcrum from the from the antimicrobial disc, or just get dressing that has infused CHG or silver. And so I do that. And then again, apply the dressing at the point of the insertion site. And then with something like this, and remember, these patients are an exception. What I'll do is I'll add another secondary dressing on top of all this, just to be able to close it up from the bottom. There's a lot of exposure here. So remember, these are not every patient. This is not the norm. I'm going over very rare cases. These are patients who have trouble with connective tissue disorder, where it could be growing through the skin up to the surface. This is a technique that you can use to keep that slope with a more gentle pressure at the bottom, if at all. Or you can have these CHG, or who else makes them? Like 3M has this one. Was it Prevahex or Covalon, or all these different manufacturers out there? Luckily, you don't have to worry about that fulcrum problem. You could just apply it at that initial insertion site, and then have a smaller, thinner pad with that gentle slope. Again, still, I'm not starting at the edges. I'm starting the application of the adhesive at the device and the catheter itself. And then I'm taping it down like this, like so. Instead of the traditional way of just slamming everything flat on the skin, I give that little slope. And I tape it in a way that it's taped like tape here, the space between the skin and the catheter. That way we still maintain that angle. Now, throughout their day, it's going to continue to get pressed down, but at least the dressing itself will not be the cause of that. So this is a very, very rare but special tip for people with connective tissue disorder. Why is it important? Well, why not just not use SecurAcath? Because a lot of times they also have issues with adhesives. And so the adhesive, I'm trying not to, slam any company, but the adhesive is acrylic, and it'll be caustic to the skin, and they'll have these rash reactions or these redness around their skin. Actually, let me show you. I know we're going over, so if you guys need to go, you guys can go, I'm sure. And then I know
there is going to be a recording. Somebody asked in the chat, and I posted the link. It takes a couple of days, but we posted our historical recordings of this type of session. We're trying to do them monthly. I'm not sure if we're going to do an April session due to a lot of conferences in April. If I get my speaker confirmed, we'll post the next date and the next link on our website. But April may be the last week in April, or early May, or we'll do one at the end of May. So we will be happy to share our recording on our website. The link is our SecurAcath.com. Go to the education tab, and it's about halfway down. It says drop-in training sessions. Historical links are posted by the host name. And so you'll see the Vascular Guy on our website in a couple of days. But if you have any questions and want to stay a little longer, please feel free to post your questions. Dennis, when you're done, I know you're still demonstrating here what to do for patients that have skin reactive concerns. But I also have links to our app and other resources that I can go over as well.
Yeah, their app is actually quite useful. Wish more people knew about it, but yes, get the app.
Okay, do you want me to share, or are you still showing?
Yeah, I'm gonna share my screen real quick.
Okay.
Can you go to this one? And then we don't need audio, but do you guys see? So this is where the wing was placed, right there. And then you're gonna actually see the imprint. Can you guys see the imprint of the wings here? The hub itself. I had a MCS patient where we kept applying the Tegaderm or the dressing to the same spot over and over, and she actually started developing a blood blister. Now, I'm sure for the majority of you, you guys don't see those issues with the patient having the hub directly on the skin. But for these patients, they're again, connective tissue disorder, they're going to have problems with any hard surfaces, any extra pressure that their body's not used to. And you can see the edges of the wings here and the back of the hub and then the front of the hub and then the rest of the catheter coming out this way. And so let me see if I could get her testimony of not actually feeling any pain. So this is share audio and sound. There we go.
Would I also need anything like heparin for the?
Right there. So this is why I love this. The nurses are going to love you because this is how easy their dressing
wow.
changes are going to be.
Much.
Okay.
So now,
Do
let's
you need to still
pull.
hold on to this?
Now you can let go. So now I can grab this. It's going to burn a little bit. It's from the rubbing alcohol chlorhexidine. So now I can handle this easily, get underneath, get all that bio.
That's not dry blood. This is actually a pressure ulcer developing because of the biopatch. Isn't that crazy? So actually, never mind. That's that's from the lidocaine injection. My bad.
Crust out of the way. That dried blood.
Did you say that was
I
from your
forgot.
injection?
Soak that
I
site.
forgot I tunneled her out. Yeah, so she's gonna
Oh,
bruise a lot in that area. I'm following up with her tomorrow
Good.
to see if anything resolved.
Very good.
So she's not feeling any pain while we're handling it. We're able to clean it pretty easily without being too careful or worry about
Here,
pisting.
I like to give
I'm not
this area
concerned
a really good
at
scrub.
all.
And man,
Can I see it?
red all over.
Oh, I also have dermographism, so anything that presses on the skin is going to leave a mark. It's like skin writing.
Are you used to skin breakdown? Coating, and so we're definitely going to feel it more.
I'm not worried at all about this catheter pistoning. Like, I'm not puckering up. I'm just doing my thing, moving forward. Like, this would be such a if I wasn't filming, this would be a significantly faster procedure. So just know that the convenience is such a, I mean, when I commit to changing their dressings and working with them long term, to follow up with my lines, I love my life. It's so much faster, easier to deal with, than having to be very careful not to piston that catheter in and out, because that pistoning is what carries the bacteria into the bloodstream. And so I love having something that's going to stop that from happening. Unfortunately, with the adhesive, was it like, I forgot what the other, besides Statlock, everyone knows Statlock, so we'll just call it Statlock. They're great for short term, but the windows, when they're off the windows, they're free and moving around. They're not anchored at a specific time during the dressing change. So what I like about SecurAcath is I don't have to worry about that. So it helps me to move faster, more bandwidth to focus on other things. So yeah, that's why I like to use it. And there's a lot of patients who are benefiting from it because of the skin and rash issues with the acrylic dressings and tape. So for them, I like to use it and prevent that suffering. Like when it itches, when we itch, for most of us, we're I'm assuming we're pretty healthy decently. The itching, if we itch from a mosquito bite or something, we can just scratch it and then it's gone after 2 days, right? Worse, it's still there after 4. But for them, it's itching forever. And so if we can reduce that itchiness and that rash, I mean, they're literally, I know it sounds stupid, but they're suffering from itching all the time. Like, it's really uncomfortable when you can't get rid of it. This is an alternative and a solution for them, so they don't have to suffer with the life-saving devices. So yeah, that's why I like using this stuff. And of course, other products out there too, but this one in particular is my favorite. But yeah, I wish I was getting paid for this.
Well, I'm glad you're not, because then it's honest.
I
Um,
know you guys are great, so I appreciate
Good.
having me in.
So I will just ask one last time if there's any last questions. If not, I'm just going to share a few resources for those who've lingered long enough. I'm going to post and share.
Sorry, just saw the message above. Can we access record? Okay. Do you have any orientation about the tape
I
reverse?
think it means reverse taper.
Like a reverse taper catheter.
Like, doesn't matter.
Oh,
Size-wise.
So that blue
because
elastomer is designed in the catheters. Really, PICC lines are the only ones that have a brand or group of brands that have a taper on them. Most other catheters are straight shaft catheters that have the same size from point A to point B. So with a few exceptions, the 3 French to 6 French catheter elastomers are designed to give. So if you can, where your thumb is right now, if you can show the towers or the little grips, those are designed to accommodate variation in the sizing along that shaft, and it will grip at the 6 centimeter mark where there's no taper all the way up to the 0 mark where there's the widest part of the taper. So as the taper gets bigger, those little elastomer arms will hug the catheter, and they're designed to give to hug. So if you lock it in at the 0 mark, it'll still hold, and it'll hold a 5 French catheter that has a straight shaft. It'll hold a 5 French catheter that's tapered up to a 7 in the same regard. But it's best to size the right device for the right catheter.
so Fernanda, first of all, miss you guys, but when it comes to bleeding, I'm not sure.
They're taking the taper out. So they were taught that the taper solves the bleeding. So plugging the hole with the taper stops the bleeding. I know
Oh,
Jack is still there. I'm sure he has an opinion about
I
that.
don't think it makes a difference. Here's why.
Okay.
First of all, we're supposed to be applying this up to the 0, but let's say it's hub 0 at the skin, and you're hitting like the taper probably starts at the 5 centimeter and then tapers out.
Something
I could
like
even
that.
see it here. So you can see the tapering and widening out. It's not how to say, okay, where is this? My dilator shaft with the sheath is going to be about the size, if not the width, of part of the taper. So the sheath itself is a larger diameter than up until about here. And you saw me even fit this part, which is probably the beginning of the taper, still fit through that dilator sheath. That dilator sheath is actually bigger than the taper itself. Now, when you hub it to all the way up to here at the skin, then possibly you can use that to stop the bleeding. But to be honest, pressure at that site, long enough pressure for coagulation to happen, is going to be the best thing rather than relying on the taper to stop the bleeding. Because what happens during the dressing changes, if you don't use first of all, the SecurAcath, you're going to have about 3 centimeters out anyways. So you're not going to be able to take advantage of that taper plug. However, when you're not using it, what happens during the dressing changes? You're going to unplug anyways, no matter what. So you want to rely on the body to coagulate and stop the bleeding, not the device itself. Because the coagulation of the body is truly what's going to stop the bleeding. Using the taper to stop bleeding is a very, very temporary measure. And if you hub this all the way to the skin, now you're going to have problems of pressure ulcers. I have a friend that works with BD, at Bard, and he was telling me that they don't recommend hubbing at the skin because this is a harder plastic. And you saw it on that video of that girl. Even the hard plastic was imprinting and causing not pressure changes, but the pressure of this hard plastic, even just laying on the skin itself, was affecting the skin. Can't imagine what the pressure of that hard edge here is going to cause on the skin. So we should not be hubbing this anyways.
Dennis, you've
Huh?
already created a wound when you put the insertion site in. So you're putting pressure on an existing wound, and that's just going to accelerate the problem.
Bingo.
But
And if you're nicking, this isn't going to stop anything.
yeah,
So that's
that cinching and holding pressure and getting that initial hemostasis is the best way to avoid bleeding at the insertion site with the SecurAcath. So if you have a SecurAcath in, once you have it placed, you want to make sure the legs are fully extended, that the feet are properly in the subcutaneous space, but then you're going to pull a little counter traction on the catheter in the SecurAcath and hold pressure at the insertion site on the surface. And that little sort of sandwiching that happens allows that hemostasis to form in that sub-Q layer so that you get that bleeding to truly stop. And then again, I would minimize exercise of that arm for a little bit because again, it never fails that you've done your pick in 30 minutes and then they want to do calisthenics right after you're done. I always joke and tell them it's not time for yoga or arm wrestling or doing their push-ups.
so I see a lot of my friends from Brazil. Nice to meet you. Obrigado. Thanks for showing up. I'm sure they may have questions about sizes. What if I don't? This is a 4 French catheter, and this is a 4 French SecurAcath. What happens if I don't have a 4 French? We ran out. We forgot to buy more, or we only have 3 French or 5 French. Can we use the larger or smaller sizes?
Are you asking me, Dennis, or are you going to?
Yeah.
So if I'm in a bind and I want to use SecurAcath, but I don't have the right size, and I do have one that's a size down, I would choose to use the nearest size. I think that if it's a bigger size, you're going to run the risk that the line could get pulled through more easily. And if you size down, you may have a little more probability of a compression or occlusion, but or resistance in fluid flow. But in general, if that were a temporary option, like I just need to anchor it today, I can go get the next size tomorrow. I would then switch the lid to the appropriate size as soon as possible, and not necessarily change my base. Again, this is a one-off solution. So because you're asking kind of a what if scenario, I would recommend in the case of a what if scenario, anytime you have any what if questions, you can reach out to us directly through our chat function. You may have to leave us a message and give us, a couple hours to come back to you, or you can call our hotline. So for our domestic customers in North America, you can call our hotline at 1-800-225-0000. Anybody else around the world can hit info@securacath.com, and we'll get back to you as soon as we possibly can with the right answer for your question. But again, specific patient scenario situations, that will get one off. But as you see, Dennis is playing here, mixing and matching combinations of sizes, and it will hold.
So let me just show you guys. I actually haven't done this yet, so it's a fun experiment for all of us to discover. I'm probably going to do a more formal hole meter to show you guys, but this is not. That's a 4 French catheter with the 4 French SecurAcath. This is not easy to pull.
And
I actually can't wait to.
Catheter is being
on mute.
compromised, so that's why it starts to slide. So as you stretch, it acts like a rubber band, and that outer diameter begins to compromise.
Yes. It's not something you want to keep doing, but yeah, this is a 7 French, and even this, it comes out more easily. However, as long as you're not tugging at it and you're changing your dressing properly. Do you guys see how even with the 7 French to a 4 French catheter, this is a 7 French SecurAcath. Not that I'm recommending this, but I'm showing you guys like the SecurAcath is going to come out before that catheter comes out.
If there's no dressing. Now, if you have a dressing.
If there's no dressing, right. So yes, you can move. This is not the opinion of SecurAcath, right? Is that how I disclaim?
Not a recommendation to use missizing.
No, but in my experience, I've run out of 4s and 5s when I had the other size, but it really worked for me. So even if I have a 4 French catheter, but I have a 5 French SecurAcath, I'd rather have something than nothing because it still works really well. Right?
On the taper for sure. If you get down to the body of the catheter where it's a true 4 French, it will still hold, but you're going to lose a lot of grip strength because it's just you don't have the size matched properly.
And if if the patient is pulling, they're going to pull anything out. You can suture their entire arm with this thing. They're still going to pull it out. Like if they're confused and have the strength, nothing's going to hold it in. However, how many of you are pulling with that much force anyways? I feel like most of us are going to be gentle with it and won't have to worry too much about overcoming that pull force that the catheter's holding. That's just my opinion, and from my experience, it still worked really well. But again, I don't recommend it. They don't recommend it. Use the size if you have it, but if you're in a pinch, it's better to have something, in my opinion. So that catheter displacement, I think, is the number one problem we're trying to solve, not just with this device, but in general. Like, I don't know if I'm allowed. Yeah, I'll say it. If your facility doesn't have this, too bad for you. Call up SecurAcath and ask them how to get some of this in your facility. But if you don't have it, then we have to use sutures. If we don't have StatLock, if we don't have SecurAcath, if we don't have anything, the number one goal and objective is to prevent displacement, no matter what. But if we can prevent that with less suffering for our patients, but also a very convenient way to deal with the care and maintenance, let's do it. Let's go, baby. But again, objective is prevent displacement. So
Yeah. And on that objective, I will say we have the most evidence of all the options out there. So most peer-reviewed evidence supporting device securement at the insertion site. And if you're curious about published evidence and not just opinions, we do have all of that available on our website as well. So please feel free to visit our website for that information. That's my commercial plug.
it is MRI safe. Someone was asking MRI safe. There's one particular scan that they have to be careful about, right? Or did you guys clear it for all?
It is MRI safe to 3 Tesla. Honestly, it's never been a clinical issue that we're aware of. I think the scan you might be referring to is a head scan, and that's only if the device is in the field of view, like if they were using it, for instance, on a ventriculostomy and they were scanning the brain, and the device was right at there might be some artifact in the image, but not to a point where it's clinically relevant. I guess that'll be the end of our talk here today. Thank you guys for joining. We will look to have another one. We'll post updates on our website. Please join us at SecurAcath.com. Like us on Facebook, Twitter, or excuse me, not Twitter, X, and TikTok, and on Instagram. Follow us and follow the Vascular Guy. He has great tips and tricks, not just on SecurAcath, but on all types of vascular access questions. If you're social media leader and follower, please engage on his social media platform for all answers to your curiosities and questions. We do have an app. Please feel free to download our app for free. And for those of you in the United States, you can always click our phone icon on the bottom of the app to contact our help desk, and we will do our best to answer your questions. We have an e-learning platform on our website that you can access for free, and these drop-in sessions are going to be happening monthly or every other month. Our next session is likely April, maybe May, but we will look forward to entertaining you. And we also have print materials available and our digital video library. So for those of you looking for videos on how-to tips and tricks, we have some posted right here on this QR code. You can access that information. Again, thank you all for joining us today and asking great questions. Dennis, thank you so much for sharing your cool technology. And now that I know it's an earwax camera, I'm going to go buy one because that is super cool.
They're about $30, $25.
Super cool.
Yep.
Awesome. And I think we got to see things in angles and ways we never saw it before and never thought to see it. So thank you all. Thank you all for joining today. And I hope we answered your questions. If not, feel free to email us at info@securacath.com. We'll look to get you those answers.
See you guys around. was a lot of fun.
Thank
Thank you,
you.
everybody.